There were several pharmacological considerations looked at when we discussed a broader use of ticagrelor versus clopidogrel for ACS patients. Number one, when you look at newer drugs, we obviously look at benefit and we look at risk. And there was quite a bit of debate over balancing risk and benefit with these new drugs. When you look back at the Plato trial and ticagrelor versus clopidogrel, the benefit of ticagrelor is actually late. It's not early. The Kaplan-Meier curves looking at death, MI, and stroke in the trial of clopidogrel versus ticagrelor, we don't see those curves separate until about a month. So we felt reasonable that we could delay the use of ticagrelor and only use it in the most appropriate patients, those high-risk patients that we felt would benefit more so from the drug. So a GRACE score greater than 140, a TIMI score of 5 to 7, those patients are high risk, and we felt that those patients would be or derive more benefit from ticagrelor. The flip side of the coin is the price to pay, and we did again debate over risk and benefit, and with bleeding, which is our price to pay with any new oral agent in an ACS group, an oral antiplatelet agent, is the bleeding issue. And when you look at the Plato trial, you see that there's no overall difference between bleeding between ticagrelor and clopidogrel, but when you take out bypass-related bleeding and only look at non-CABG-related bleeding, we do see that the more potent drug does in fact cause more bleeding than clopidogrel.